much. So first of all, thank you for this opportunity and very good morning from Brooklyn. So the topic we're going to talk today is vocal fold leukoplakia. Just to introduce myself, my name is Dr. Sara Abu-Ghanem. I'm assistant professor at SUNY Downstate and have a great interest in laryngology. Okay, so there's no disclosures. So the first part really of this talk is just to give a brief introduction and to get us all on the same page. In terms of the larynx, as we all know, the larynx is usually subdivided into three sections: the supraglottis, the glottis, and the subglottis. The supraglottis is further divided into suprahyoid and infrahyoid epiglottis, the false vocal folds, the ariopilartic folds, and the arytenoid complex. And its lower border would be the junction of the ventricle and the true vocal folds. The level of the glottis, as we all know, is of course the level of the true vocal folds, and its lower border is 1 centimeter below the junction of the ventricle and true vocal folds. And last part or last section of the larynx is the subglottis, and its lower border is the inferior border of the cricoid cartilage. Another two things that we need to keep in mind is basically the epithelium or the lining of epithelium. Both the supraglottis and the subglottis are lined with respiratory epithelium. However, the glottis, and we'll see later on in the lecture why it's so important, the epithelium there of the true vocal fold is non-keratinizing stratified squamous epithelium. To remind us all, the histology and 5 layers of the true vocal fold. The most superficial one, this is taken from Cummings, your textbook. The most superficial one is the epithelium with the mucosa and submucosa. Then we have the 3 layers of the lamina propria, the superficial, intermediate, and deep one. And deep to all this is, of course, the thyroarytenoid muscle. So let's start with some cases to get us all started and excited about leukoplakia. So this is PK. She's a 43-year-old female that I saw in clinic, and she came to clinic, and her main complaint was change in voice. She has very interesting history of nasopharyngeal carcinoma, and she got chemoradiation back in 2009. You can see here the list of medications. The most recent change that the patient is mentioning is starting steroid inhaler and long-acting beta agonist. She's a current smoker, but she's very motivated to stop smoking, and family history, nothing really relevant. When we dig in terms of her history and voice change, she described 6 weeks of voice change that started after a cold, but unfortunately her voice never recovered. She has a baseline dysphonia, but still now it's really got worse, and her VHI index is 24 out of 40, and talking just make it worse. Other things in terms of her history, as expected with patient head and neck cancer survivor, she has solid dysphagia, and due to her cough and wheezing, she was recently prescribed with steroid inhaler. This is her exam. Let me just move this here. So this is her physical exam, as you expect to see in patients with head and neck cancer, very dry mucosa, and we see the crusting and loss of anatomical landmarks. And here, if I'll move a bit forward, as we can see, her true vocal folds and involvement leukoplakia. What we see here is basically involvement of almost all the right vocal fold and the posterior part of the left vocal fold, and there is sparing of the anterior commissure. In terms of our stroboscopy, as we expect to see, there is reduced mucosal wave bilaterally. There is irregularity and incomplete glottic closure. Okay, here's another case for my fellowship, 67 years old, hoarseness for years. Nothing really to mention in terms of his history. He's a former smoker, and he stopped really long time ago in 1996. His main complaint is progressive vocal decline for the past 12 years, and he was mainly sent by an outside ENT that scoped him and saw a vocal fold lesion, and that's why he ended up in our clinic. So that's his exam. I'm just going to move forward to get closer. As you can see, are very similar to the other patient, but I would say thicker leukoplakia lesion involving the left vocal fold and the right side, again with sparing of the anterior commissure. And last case for this morning is a 76-year-old male with 8 weeks of hoarseness. He's a heavy drinker, so that's something that we need to keep in mind. He describes 8 weeks of dysphonia following a concert with no prior history of voice complaints. And his exam looks like this. I'm sorry.
Clear throat.
So his leukoplakia was more nodular appearance to it, and it was involving the left vocal fold and the anterior part as well. Okay, so when I started working on this presentation and preparing it, I wanted to have like a nice definition of leukoplakia, and I was very amazed with the different definitions out there. Most of them in the head and neck area would be for oral leukoplakia. And you can see here with this nice review from 2007, how the definition really changed and progressed during the years. The initial definition by the WHO in 1978 is basically, of leukoplakia is basically a white patch or plaque that cannot be characterized clinically or pathologically as any other disease. In 2005, the WHO revised this definition and said that it's a questionable risk, white plaques having excluded known disease or disorder. And I think what my favorite definition is the one that was proposed in 2015 by the same team member of the WHO 2005 definition, that basically this person's, this author suggested that the new definition should be a combination both of the 1978 and the 2005, basically advocating for pathological specimen in all leukoplakias in order to exclude any risk of cancer. In terms of the differential diagnosis, as we all expect, the most important thing that we all want to exclude and rule out is precancerous and invasive cancer lesions. But other etiologies that have been associated with leukoplakia, that includes LPR and GERD, exposure to different chemicals, vitamin deficiency and hormonal dysfunction. Other things that we're going to see also later on is voice abuse, chronic laryngitis, infection, and mainly fungal one, and dry mucus or mucosa is another thing that can look like leukoplakia. In terms of the epidemiology, as you can all imagine, it's very hard to really know what the epidemiology of leukoplakia. This is one really old paper from 1991 that says that the incidence of leukoplakia is much higher, 5 times higher in males than females. Obviously, most of the literature of leukoplakia would be related to precancerous and invasive cancer. And we all know that that would be more in the adult patients, males, and the known risk factors of smoking and alcohol. In terms of the histopathology, if we go back to our second slide, when we talked about the normal epithelium, which is usually non-keratinized, leukoplakia by itself describe or indicate the presence of keratin in the epithelial surface. And this is obviously means that there is a change in the epithelium. If we look at the classical classification, if we took a biopsy from that thing, most of the pathologies will be grouped into three different groups. Can be either benign, like hyperplasia with or without keratosis. It can be either one of the dysplasia, and we're going to talk about this in a moment. And then the far end is the carcinoma in situ and the invasive cancer. The dysplasia itself, the classical classification, as we all know, the WHO that most of us are using, is the mild, moderate, and severe, and the carcinoma in situ. A lot of times we'll see pathologists using severe dysplasia and carcinoma in situ together. Another classification that we're all familiar with is the Ljubljana one. That's another classification for dysplasia. However, I do want to introduce us all to the new classification from 2017 of the WHO, that basically it's a very nice classification, makes it so much easier, saying that from now on, we're not going to talk about so many different subgroups of pathology result, but either low-grade dysplasia that has low malignant potential, or high-grade dysplasia with high malignant potential. The low-grade dysplasia will include all those categories of hyperplasia and mild dysplasia, and the high-grade one will include moderate, severe, and carcinoma in situ. I feel like this is really makes it much easier to understand better what to do with the patient and how to treat them. So the question is basically right now is, what is the incidence of precancerous diagnosis once we do take a biopsy from this leukoplakia lesion? I guess that's probably the biggest, the largest series about this subject from 2008. And here what they did, this group of, is they took their experience and they also did a review of the literature. Overall, they had over 1,000 patients, which is a lot. And what they found is if you take pathology of this leukoplakia lesion, there's 50% of it not to find any dysplasia or nothing like this. 33% will be found with either mild or moderate, and 15% with severe dysplasia or carcinoma in situ. I couldn't find there the rate of the invasive cancer just based on leukoplakia. Next, the question is, okay, I found something on the pathology. What is the next step? And what is the risk of that thing to progress to be invasive cancer? So most of the studies about this is that there is a greater malignant transformation with advanced histopathological or dysplasia grade. The same paper looked at the malignant transformation for each group of dysplasia grade. If there's no dysplasia at all, there's still minor, it's not minor actually, 4% risk of malignant transformation. 10% during the follow-up period progressed out of the mild to moderate dysplasia, progressed to have malignant transformation, and 18% of the severe dysplasia and carcinoma in situ indeed progressed to be malignant transformation. So that's pretty big numbers. The head and neck, in the Head and Neck Journal in 2016, this systematic review was published, and I was shocked to see the numbers over there of the rate of development of invasive cancer based on grading. Look at the numbers here. Mild dysplasia, up to 40% of patients or cases will transform to malignant transformation. Moderate, up to 48%. And as expected in severe dysplasia and carcinoma in situ, very high rates or higher rates. But I think the most important thing really to remember of all those papers is that carcinoma or invasive carcinoma can really develop from any grade and even from normal epithelium. If you remember this part by the end of this lecture, I think that's the take-home message that we all need to keep in mind. If we saw something in the larynx and we took a biopsy and we saw hyperplasia, that doesn't mean that we're done and we're not going to follow this patient. This patient needs to be followed later on. So back to our patients. What do we do then? How do we differentiate between benign, precancer, or cancerous lesions? How do we know? So of course, in order to establish diagnosis, we need to know the patient history. There are different other options, like to continue just follow-up and do serial exams. We can treat the patients with different medications or send to voice therapy and see if there is any response or any change in the lesion, and biopsy and surgical treatment. Of course, everything is when it's indicated. In terms of the presenting symptoms, when we dig in terms of the history, nothing really in the symptoms will scream or say this is cancerous. Some of those patients will be found with leukoplakia, just an incidental finding. Some of them will come, and a lot of them will come with just sore throat, throat irritation, the common things that we see in laryngology clinic or ENT clinic, and dysphonia. So there's nothing really specific, as we know, for cancer. Other things that you would ask, of course, like any other patient, ENT patient, you need to know about the past medical history, the surgical history, recent change in medications, and most importantly, the risk factors like smoking and alcohol. This is something that I usually use, the voice swallowing airway parts when I do take anamnesis, especially or history in laryngology clinic. I like separating all those three to make sure that I covered all throat symptoms and complaints. And there are different questionnaires out there that you guys can use in your clinic. This is just one option that I really like. The reason why I really like this questionnaire, because I really adopted this this open question to ask my patients when they come to a laryngology clinic with dysphonia. Just describe your voice in your own words. Don't just give them the hoarseness and move on. There are so many different beautiful aspects to the voice that patients can share with you. Of course, we have the VHI questionnaire and the E10 that we're all aware of, and the physical exam. After the full head and neck exam, we're all gonna move on to do a laryngoscopy. When we do see, guys, leukoplakia, it's very important to describe in your report, your endoscopy report, the pattern of the leukoplakia and how does it look. Is this leukoplakia lesion involving unilateral vocal fold or both vocal folds? If there is involvement of the anterior commissure, do you see any extension to the supraglottis or the subglottis? Of course, it's so very, very important is the vocal fold movement, especially later on if that's indeed a cancer, and vibration under stroboscopy. In terms of the leukoplakia pattern, usually we divide it into two different subgroups, either homogeneous pattern or non-homogeneous one. There is importance to that, and there are fairly good amount of papers just saying that based on morphology and patterns of the leukoplakia, you can really tell if indeed that will be cancerous. And as we all expect, smooth and flat leukoplakia lesions has a lower rate of malignancy compared to this rough or hypertrophy lesions. So obviously, if someone comes to clinic, we have higher degree of suspicion if we see those rough leukoplakia lesions compared to the smooth, flat ones. So again, there's no clear management protocol for vocal fold leukoplakia. We can either, once identified in the clinic, we can either do a wait and see approach. We can try, as I said, different trials like antifungal trial. We can do voice rest. Some people prescribe PPIs. And of course, the other things to keep in mind is basically the biopsies, that we have two main options, either the in-office biopsy or surgical biopsy in the operating room. Let's go on some pictures of leukoplakia lesions, and we can all agree, I think most of them, either to biopsy or not. That's a 62-year-old female, and you can see those leukoplakia lesions involving all her larynx. She has a history of diabetes, and she's using steroid inhalation. I think we can all agree that probably her leukoplakia is related to the steroid inhalation, and at that point, we'll probably maybe ask her to do some rinses after the inhalation and just do some repeated exams to see where it's going. That's another example, leukoplakia, or for us, it looks like a white patch over there. But obviously with this 38 lawyer with hoarseness of 3 months, this white lesion here is a reactive one. And it's reactive to the lesion on the left side. After voice therapy, of course, this lesion will disappear. That's another leukoplakia. If the SLP that is doing right now fees for this post-intubation patient, this is nothing really concerning. And of course, this is either granuloma and granulation tissue, and there's nothing really to do here. Just wait and see. So when do we really biopsy? Are we really biopsy everyone? From the operative techniques in laryngology, the authors suggest that the indication really to do a biopsy is when histopathology has not been established, and they describe, especially in cases when in stroboscopy, the mucosal wave is reduced or absent, or if there's a change in appearance or nature of pre-existing leukoplakia. Since there are not really good guidelines, there's a lot of effort out there to really help us clinicians in clinic or doing those scopes to really know which are those patients are really at higher risk and which of those patients we need to really biopsy. Unfortunately, most of those techniques that are listed here in this list are really not really helpful to replace a biopsy, but more to guide surgeons in the microsurgical intervention, not to cut more or not to biopsy more than really needed. So let's go over some of those techniques or some of those tools that were suggested. In terms of the video stroboscopy, a lot of us feels that the video stroboscopy can help us with differentiating pre-cancer, I would say benign and cancerous one. This is one example of one study. There are several of them that was published in 2017. A fairly small number of patients, but what they did is basically they divided the patients to preserved mucosa with leukoplakia, to preserved mucosa wave or reduced or absent mucosa wave. And as expected, they saw higher rates of malignancy or invasive carcinoma in the patients with reduced or absent mucosal wave. Their sensitivity and specificity, as you can see here listed, 96% and 93% are fairly high. And they summarize the overall accuracy of stroboscopy in prediction of 95%. Others actually said different or found different results and actually suggested that stroboscopy is not really a reliable tool. Some of them said, explaining that, basically saying that it's just a mass effect. If the leukoplakia, just imagine a thick leukoplakia lesion, of course, that will affect the mucosal wave, and it's not necessarily because it's invading the mucosa or invading to the muscle or the basement membrane. It's just because it's just a mass effect, and that's all it is. So we need to keep that in mind too. Another other things that you will find in your textbook, not really in use, is the OCT that we all know from our ophthalmology rounds. The OCT is high resolution imaging technology that basically look at the vertical cross-section images. In terms of the use of the OCT in the head and neck, this is one paper that's describing that. That basically they use the OCT probe through the scope and they just place it onto the tissue. When you think about this thing in larynx, how do I really do this in office? How do I put the OCT probe on someone's vocal fold to assess? It's really hard. This is one example of two papers that were published by the same group in 2006 and 2009, showing the use of OCT in clinic and how you can really nicely see image of healthy vocal folds and the layers of it. Obviously, there's a lot of, the main advantage of the OCT is the depth of penetration. Again, with those thick leukoplakia lesions, that this is not really helpful. Another thing that was suggested that can help us differentiate benign or malignant lesions when we see leukoplakia is the use of autofluorescence. laryngoscopy, the autofluorescence, the AF is basically the natural fluorescence. When you activate by a specific wavelength, you can see normal versus neoplastic patterns. So the normal is usually green, and the red-violet one would be more the neoplastic ones. There's a lot of false positive and false negative in this kind of things, especially since scarring, hyperkeratotic lesions, and inflammation can sometimes look like things that they are not, like cancerous. So that's a problem. So someone thought, okay, maybe I can help see better the autofluorescence if I'll just use this ALA compound and just use it topically on the laryngeal mucosa, just nebulize the patient before the exam. And the logic behind this is this compound will have higher concentration in precancerous and cancerous lesion compared to normal tissues. You can see here on C picture or image. However, based on studies, the addition of the ALA to the fluorescence really was not found to improve the diagnostic accuracy. And I don't know a lot of people who are really using this. Another two tools that are described in your Cummings textbook is the contact endoscopy and confocal endomicroscopy. Again, very nice tools to see 3 dimensions and very high resolution images, but not really in use. I think of all those techniques that I just described, probably the most common one or in use is the narrowband imaging. And this narrowband imaging is basically help us to identify superficial capillaries and angiogenesis, basically formation of new blood vessels that we really see fairly often in precancerous and cancerous lesions. This is just one example of how normal mucosa looks like in regular light and narrowband imaging. And this is the pattern that we see in abnormal mucosa. This study, for instance, found the sensitivity of narrowband imaging in leukoplakia to predict malignancy, the sensitivity of 88% and specificity of almost 90%. There are different classifications for that, and I think it's really up to the clinician and his experience to recognize this. If you don't have a lot of experience with that, when you start doing the narrowband imaging, a lot of them looks pretty much the same unless it's really normal. So it's really up a lot of experience to that. So really, it seems like we're really left with biopsy. They really don't have a lot of options there. The gold standard of the biopsies, we can either do it with cold instrument or with laser, and we can do office biopsy. And cytology or brush is not really something that no one's really doing because we need to have a good biopsy and deep enough to know if it's invasive or not. If we look at the office-based biopsy, the advantages and disadvantages, of course, advantages is we avoid general anesthesia, especially with those high-risk patients. It's easier to schedule or do it in office as the patient is diagnosed with leukoplakia lesion. It's reduced cost. Most of the time, you're really able to get nice sampling. And the high predictive value is pretty high. If it's cancer, it's cancer. The disadvantages is really difficult to assess if the lesion is pretty spread around. It's very hard sometimes to assess how much of it goes into the ventricle or how much of it goes down to the subglottis or to infraglottis. You really need a patient that is cooperative to handle with this biopsy in office. Sometimes it's difficult to get good sample or a deep enough sample to know if it's indeed invasive or not. And the issue of false negativity is a very problematic thing when we discuss the in-office biopsy. This is an example of a paper that was from Israel with 117 patients, and all patients had leukoplakia, and all of them also had all of the patients that were found with benign or carcinoma in situ pathology on their in-office pathology, they went to do a DL, which is really nice, because how many papers or studies do you know that all patients had both in-office and direct laryngoscopy? However, if you can see here, the number is pretty low. Sensitivity is 70%, specificity is 97%, and as you can see here, in the negative predictive value is 57%. Could be used as initial diagnosis tool for laryngeal malignancy for early detection and avoidance of general anesthesia. However, operative rebiopsy should be considered when severe dysplasia or carcinoma in situ were reported, or of course, again, if you have suspicion for malignancy. So if we'll go back to our patients, what did we decide to do with them? The 76-year-old patients that I first described with 6 weeks or 8 weeks of dysphonia and heavy drinking, this patient actually underwent an office biopsy, and he was found with negative for dysplasia or carcinoma. And he underwent in-office KTP laser treatment. That was, again, during my fellowship. The second patient, the 67-year-old with a really spread leukoplakia over there, he underwent surgical biopsy in the operating room. There are different ways how to do it. Again, the same textbook with the operative techniques in laryngology. What they describe there nicely is how you can do it, basically raise the flap and resect the leukoplakia lesion. And of course, keep the orientation when you send that to pathology. Our patient, his pathology result was found, again, negative to carcinoma, and that's him during his follow-up. I'm sorry. So as you can see, he has still residual leukoplakia there, or recurrent leukoplakia there. And here is just, we just need to follow this. And last is the patient with an nasopharyngeal carcinoma. With her, I just treated her with diflucan, and that's her exam post-treatment.
Sorry. No, you didn't.
So as you can see, the leukoplakia totally cleared. So that's really nice. So to conclude, in terms of laryngeal leukoplakia, there's no clear management protocol for treatment or management. You can either wait and see. Medical treatment that was suggested, as I said, is PPI or antifungal. And we have the options of biopsy, either in office, or the gold standard is the operating room. As I described, there are different efforts and techniques out there to help us to replace biopsy, or mostly to help us to resect less normal tissue. And the most important thing is that clinical judgment and high degree of suspicion are the main indications for biopsy. That's it. Okay, any questions? Can't see the other screen. Okay, so you have my email here. If you have any question, feel free to shoot me an email. And I think that's it. Dr. Gupta, is there anything else?